Hi there, and welcome to this presentation on massive haemoptysis. My name is Chandra Ori. I'm a consultant respiratory physician at Glenfield Hospital in Leicester. The definition of massive haemoptysis really depends on the volume of blood that's being coughed up. And there are various different definitions which exist depending which source you look at. But generally, we sort of talk about a ballpark of more than 240 mils of blood coming out in a 24-hour period, or more than 100 mils per day over consecutive days. Now, various sources will quote other figures, and I've seen things between 100 to 600 mils or more per 24-hour period. But again, as a rough suggestion, I'd stick with these rough values. Now, clearly, massive haemoptysis can be life-threatening and is often associated with other common symptoms, including anxiety and shortness of breath. And less than 5% of patients presenting with haemoptysis will actually have a massive haemoptysis. So it's not that common, but it is common enough to be able to have to recognize it and also realize that it's a medical emergency which requires prompt assessment and management. So thinking about causes of haemoptysis, well, this is not an entirely exhaustive list, but really sort of concentrating more on the common causes. Clearly, we can see that at the top there are things which are associated with infection, but also inflammation within the lung airways. And these are things which are conditions which are often chronic, like bronchiectasis or cystic fibrosis. But it can also be, less long-standing, things like TB and lung abscess as well. And this group of conditions which cause these sort of infection and inflammation in combination are really the most common causes of haemoptysis. Lung cancer is also a common cause. And then we also sometimes see, other types of infections such as necrotizing pneumonia or mycetoma. There are many other rarer causes which you'll have recognized, but we won't go through these in great detail today. So thinking about the management of massive haemoptysis, well, really, obviously, you want to be able to promptly recognize what's going on and resuscitate your patient accordingly, as with any medical emergency. And clearly, airway protection is of the utmost importance. And clearly, if we're struggling in any way with airways competence, then we may need support from our intensive care colleagues if the airways is compromised in any way. We want to establish IV access and deliver some IV replacement as soon as possible, so that's usually simply IV fluids. Occasionally we need to think about blood transfusion, but it's fairly rare in the acute setting in massive haemoptysis to get a large drop in your hemoglobin. And then thinking about some immediate investigations, well, clearly routine bloods will be helpful, including cross-match. There are many other blood tests which we may consider depending on the underlying cause of the haemoptysis, but again, I won't go into that great detail about that at the moment. Clearly, if a patient's hypoxic, an ABG would be useful. And again, if we're thinking about some sort of effective etiology, then some sort of microbiological investigation of the sputum would be very useful. An early chest X-ray. And then if the patient's hemodynamically stable, then certainly a CT scan would be important. And the sort of modality of choice here is a CT aortogram, which is very useful at looking at the bronchial artery tree. And it's really trying to look for any focal site of bleeding. And the reason that's important is if you think about the causes of haemoptysis, again, really when we've got things like infection, which are the commonest cause of haemoptysis, it can cause an irritation of bronchial arteries in the airways. And that infection and inflammation irritating the bronchial arteries can really cause those arteries to start bleeding into the airways. And that's why you often get the sort of syndrome of haemoptysis. So thinking about the underlying cause is important. And in terms of other sort of initial management steps, treatment, obviously, we want to think about giving something which is going to stem the bleeding. So tranexamic acid is a useful antifibrinolytic agent, which we can use either orally or IV. And then by this stage, if we've done our CT scan and we've identified if there is a bleeding bronchial artery, if we understand which side of the thorax that bleed is on, then it's important to lie the patient on the side of the bleed to protect the other lung from filling with blood. So for example, if you've got a right bronchial artery in the right lung which is bleeding, clearly if you lie a patient on the right hand side, it's going to help protect the left lung because of gravity, preventing the left lung filling up with blood and therefore preserving that and helping maintain some physiological function in the other lung where you've not got the lesion or the bleed. So that's really an important sort of measure to consider. Also, depending on the underlying cause, for example, if it's caused by some sort of coagulopathy, then clearly there are different ways to try and manage that. But, as we said, the majority of cases that we will see are due to infection, and therefore it's important to start patients on appropriate antibiotics, depending on what we think the underlying infective organism is. And usually we see this in our patients with bronchiectasis or CF, and most of them will have had recent or historical sputum microbiology, so you may have something to go on in terms of trying to choose an appropriate IV antimicrobial in the first instance. Further management to consider. So there are other things that we could arrange if a patient has persistent bleeding despite that initial medical management. Then we could arrange something called a bronchial artery embolization, which is something which our interventional radiology team can undertake. I'll come back to that in a bit more detail in a second. A bronchoscopy may be appropriate, and if it's a very urgent situation, then you're going to have to get input from our thoracic surgical colleagues to consider doing that. And subsequently, if the bleed persists and it's found to be a very localized bleed within the lung, but it's causing significant symptoms and morbidity, then it may also be appropriate, with the advice and input from the surgical team, to consider doing a localized resection of that part of the lung. But this is really probably the most common intervention that you may be required to request in the first instance if you've got somebody with massive haemoptysis. And it's a bronchial artery embolization done by our interventional radiology colleagues. And the pictures really show some angiography, and what happens is that the radiologist can insert a catheter into the patient via the femoral artery, which then passes up through the aorta and then eventually into the bronchial artery, and using X-ray fluoroscopy, the radiologist can see exactly where the tip of the catheter is, and clearly if there's an ongoing bleed, they can try and stop that bleeding in that particular offending bronchial artery. And there's different techniques that are used for that. Sometimes there are coils which are inserted by spring mechanism into the bronchial artery, or sometimes they can inject sclerosing agents like alcohol, again just to try and stop that particular artery bleeding. Now there are some risks attached with this. It's an invasive procedure, so again, there are other things to consider. But these are relatively rare risks, but clearly they're things which the patient would need to be consented about if undertaking this procedure. Now, the in-hospital mortality from massive haemoptysis it can vary really depending on the volume of the haemoptysis and also what the underlying cause is. And this data is relatively crude. It's from older data on a fairly small number of patients, so it's not entirely perhaps up to date, but it does illustrate a good point, showing really that the bigger the volume of haemoptysis, clearly the higher the risk to the patient. And also we can see in terms of malignancy, there's a much higher in-hospital mortality associated with that than, for example, infection causes, which by and large should be reversible as you treat the underlying infection. So just one very brief case example, and the reason I've put this in is because I've seen quite a few cases of patients presenting with both PE alongside massive haemoptysis, and it's a really challenging balance to think about how you're going to manage these two conflicting sort of conditions, which are both in their own right emergencies. So you've got on one hand the PE, which conventionally you'd anticoagulate, On the other hand, you've got massive hemoptysis, where you wanted to try and give antifibrinolytics to. So, again, the question is really, what do we do in that situation? Do we anticoagulate or not? What are we going to do about the hemoptysis? Well, it kind of goes back to what we just talked about, that we could arrange an urgent CT aortogram, and this is what I've done in the past, and clearly considering bronchial artery embolization if it's appropriate and there's an amenable artery to do so. And then once that's done, then you can clearly establish and treat the underlying cause of the hemoptysis. And then once you're happy that you've got some clear pathway for hemoptysis management, then you could initiate under close supervision low molecular weight heparin or even possibly IV heparin for your underlying PE. So the massive hemoptysis key learning points really are, it is clearly a medical emergency. And as with all emergencies, resuscitation is important. And clearly, if the patient is unstable or we've got a compromised airway, then we need prompt support from our ITU colleagues. We need to use antifibrinolytic therapy unless contraindicated. So tranexamic acid is really the sort of first line for that, as well as appropriate antibiotics or antimicrobials if an underlying infection is suspected, and that will probably be the case in the majority of patients. Once the patient is stable, then we need to consider doing a CT angiogram or a thorax, and then depending on what that shows and what the underlying cause is, then we'd refer appropriately to, for example, interventional radiology or thoracic surgery, or even oncology if there was an underlying malignancy which is causing the hemoptysis. So just to finish off, there are a few resources which I'd recommend, and this links in well with our Glenfield Hospital Respiratory Handbook for Junior Doctors, which is available on the intranet. And in terms of massive hemoptysis guidance, main sort of national guidelines which exist really are embedded within the NICE cystic fibrosis guidelines if you want to refer to that. Many thanks for watching today.